morning, and thanks all very much for your time this morning. As you can tell, while the company is from Florida, I didn't really live in Florida, so this is actually close to home for me. I joined RTI about 15 years ago. Before that, I was working as a consultant in the biologics and orthopedics sector, and became somewhat fascinated with the use of biological materials and as an option within the orthopedics world. So for about the last 15 years, I've been working with a company that is primarily an allograft company, and we also have devices and other products, but my background is medicine and the biology of healing in particular. So to give you a little sense of sort of passion behind some of the things I have to say. What I will say about my talk today is while I am here representing RTI, that's who I work for, my real goal here is to provide general information and education about allograft, about availability, about processing, about the literature, about the continued research that is necessary in order for us as a community, both as providers of biological materials, as well as the physicians that utilize them, and ultimately the patients that benefit, that we actually apply ourselves to some legitimate research to demonstrate, if you like, the efficacy of all of the steps that all of us take. And I think that theme has begun a little bit this morning with Ian's phenomenal introduction to the morning. So my talk is primarily, does it matter where your allografts come from? And even though I come from a specific allograft company, I'm fairly agnostic to where allografts come from in general. What I will say, because I was paying very close attention, there are opportunities for pediatric allografts for whoever was looking for a pediatric allograft. It is a specialty product. They do have to be sourced very specifically, but it is something that can happen. So whether it happens here in Europe or whether it happens in the United States, those things can be achieved, but it is not the norm. And then what do we need to know about the ins and outs of graft procurement and graft processing techniques, and indeed, why do we process allografts? We can all harken back to the days of departments of orthopedics with their femoral heads and odd bits and pieces of cadaveric tissue that they managed to gather, and everything was in the freezer, and provided there was somebody there that knew how to switch the freezer on and off, we were in business as a tissue bank. And in the United States, we started to shift away probably about 15 to 20 years ago from that model. In Europe, only about 10 years ago, we shifted away from that model with increasing regulation. I have to say, I came away from a meeting over the weekend led by Peter Verdonk, and he was expressing massive frustration with the regulators in Europe, in the European Union, because we don't have a single rule for allograft in the European Union. We have 28 rules, which has really dramatically limited the availability of biological materials for transplant. And there's mass frustration across the European continent because of that. So what should we be considering here? I'm going to talk a little bit about the background to allograft preparation, allograft sourcing, a little bit about processing, a little bit about how preclinical study has been conducted to date, primarily by fairly large tissue processors in the United States. And then on clinical outcomes, if we have time, a literature review. Really, my commentary on the literature review is, again, somewhat similar to the commentary that Ian made this morning. And that is that some of the literature out there is relatively poor in quality, and I do question the screening and editorial review in some of the journals these days. We really need to have, as again a community, a focus on developing level 1 clinical data for biological materials in orthopedics. Historically, a lot of it is anecdotal, lots and lots of meta-analysis, none of which is particularly relevant or statistically valid, and it leaves us with very little to argue when the payers start raising questions about, well, is this something really worth doing, using, applying in the clinical setting? So we collectively, again, have a responsibility to go forward with that. Certainly with Peter Verdonk last week, He announced that he has 50 meniscus patients waiting that he can't get paid for in Belgium because the Belgian system has simply stopped paying for meniscal transplants. And so companies were basically working with Peter last weekend to see what we can do to provide meniscus for him to do his study, because he wants to be able to produce the clinical data. So that offer, I think, is out there from many of the larger tissue providers these days. We have as much interest as you do in providing good clinical data. A little bit of background. In the United States, where allograft usage is certainly much more widespread, about 2.5 million allografts were distributed in 2012. It's versus about 350,000 in 1990. So significant numbers of allografts have been distributed and are routinely distributed. And infectious disease and adverse events are uncommon, but they do occur. And when they do, there is substantial morbidity. There have been some deaths in the United States. It is rare. There has been the occasional infection, even as recently as 2 years ago. A 2-year-old was infected with hepatitis C from a minimally processed graft. So it creates many problems for us as tissue banks, for you as physicians, and clearly for patients, because a very small percentage of patients may be subjected to a risk of infection, whether it be viral or bacterial. But for them, it's 100%. So in the United States in particular, over the last 15 years, many tissue processing methodologies have been developed to help to overcome some of the risks associated with disease transmission. But what I will say is part of the reason that these numbers are so huge is because in developing these tissue processing, disinfection and sterilization techniques, what it has done is allowed for provision of allograft that was historically under strict microbial control, culturing when the tissue is sourced. More than 60% of tissue is contaminated in some way when it's removed from the cadaver. It's part of the natural process of if you like, degradation post-mortem. So massive amounts of tissue are lost if all you're going to do is try to preserve it in its fresh form. So processing developed over time as a safety measure, but it also increased availability because disinfection and sterilization can reduce the microbial flora and make more tissue available. So why is there contamination? Well, there's inherent contamination from native flora. It's part of the natural decomposition process. It can be adventitiously introduced even with the best aseptic techniques. Occasionally, technicians during the recovery and procurement process will contaminate tissues, and small lapses in aseptic technique can create a fairly significant proliferation in bacterial flora in particular. What really we need to understand is we cannot avoid that cadaveric tissue could be contaminated with bacteria. It is possible to avoid, to a great extent, viral transmission, but again, not completely. So certainly you can mitigate the risk by recovering tissue pretty quickly after death, typically up to, in the United States, up to 24 hours maximum for post-mortem. But peripheral blood can become colonized even within 6 hours post-mortem. And particularly for younger donors, they've often gone through some sort of traumatic event, and they've been vented. They've got other concomitant issues going on. So it is not reasonable to expect that we're dealing with a sterile tissue when it's recovered. Now, what do we do to help to overcome some of that? Well, all donors are screened for risk factors. Some of you may have heard that a very small proportion of donors ever make it into the donor processing, the tissue banks. Absolutely true. About 4% of all possible donors, and a possible donor in the United States is anyone who dies in a hospital setting is a potential donor. Hospitals are actually required through their conditions of participation in the Medicare system, the specialized medicine system, they're required to report every death. And so theoretically, every death is a potential donor. In reality, because of medical conditions, because of timing delays, because of authorization and consent issues, a very small proportion of those 4% of all potential donors ever make it to a tissue bank process. And in addition to meeting US requirements, AATB requirements. Our donors, for example, at RTI Surgical, are screened in accordance with international requirements. An example would be, for example, in the United States, European donors who have lived on the European mainland for more than about 3 years in the last 20 are not accepted as potential tissue donors in the United States because of the theoretical risk of variant CGT. In Europe, that's not a requirement. However, in Europe, there's a fair degree of concern about West Nile virus, which is not a particular concern in the United States. So there are different requirements either sides of the Atlantic, and very little consistency in some of these outlier requirements around the world. Pretty much all tissue organizations that are bringing tissue into Europe are doing exactly the same as RTI. All tissue banks receive donated tissues from independently registered recovery agencies in the United States. They're all organized and overseen by the United States FDA. Screening includes medical records, medical examiner and coroner records, lab reports, pathology reports, and radiology reports, when they're relevant. The lab reports are primarily serology for relevant communicable diseases. In the US, all donor eligibility is determined by a physician. That's actually not a requirement in Europe, but it is in the United States. And in common with most other tissue banks in the United States, RTI has a range of physicians that we utilize in donor eligibility. And again, less than 4% of donors make it through the entire process. So what are we talking about when we talk about allograft-associated infections? Generally speaking, since 2005 was an inflection point in the United States because new regulation came into place. It was also the time point at which the nucleic acid testing for viruses of interest became much more commonly available and became adopted by all of the tissue banks. And that helped to reduce the window period and therefore the likelihood of disease transmission from a viral marker. And as you can see, in the past there were transmissions of, and past is pre-2005, transmissions of a number of organisms. 2005 to present, a couple of bacterial organisms, group A strep, Clostridium, and most recently I mentioned due to a lab error, basically human error in a lab testing for hepatitis C. A 2-year-old was infected with hep C in Boston. Very, very unfortunate and totally unnecessary. And then in the future, what are we thinking about relative to emerging allograft-associated infections? Well, pretty much routinely we get calls, and my calls this week are about the Zika virus. So should I be concerned about Zika virus? Now, the answer to that is yes, we should. We should be concerned about whether it's MERS, SARS, you name it, there's a new virus popping up virtually every day. So to what extent do we need to be concerned? And this is where some of the processing that has been developed over the years can help. And I'll get to that shortly. But reality is, Zika is a pathogen of interest. It is certainly capable of transmission through certain types of tissues. And so if a company or a tissue processor has validated for families of viruses, then you can take a look at Zika and see where it fits. Well, it's actually of the same category of viruses as HIV, which is pretty interesting, because HIV and that entire family of virus is actually pretty highly resistant to irradiation, which is one of the sterilization mechanisms that is available for tissue processing. It is much more highly susceptible to chemical sterilization. So different viruses are susceptible to different types of methodology. So each time one of these new viruses pops up, we work in our medical affairs department with our epidemiologists and take a look at all of the work that we've done in our research, and I know the other tissue banks do the same. Is this new virus a bigger challenge to us than anything in the past? Is it easier or more difficult to kill than HIV, for example, which is our sentinel virus in that category? And we would revalidate for the new virus should one come along that is of more concern. Touch wood, so far that hasn't happened, but it's guaranteed to happen at some point in time. So after donor screening, the risk of disease transmission remains when only screening and testing are used, because there is risk. Most cadaveric or deceased donors, as we call them, are not giving their own medical history. So you're dealing with a close relative or a friend who knows a lot about them. You may, if they've had a hospital stay, you may have some hospital records, but not necessarily their entire social history that may have some high-risk behavior associated with it. And indeed, the hepatitis C transmission that happened a couple of years ago was directly associated with high-risk behavior. Young man, killed on a motorcycle, mother gave the medical history, and the young man was a saint. Of course he was, and to have hepatitis C and his mother didn't know. And he hadn't had routine medical care, so hit by a motorcycle, hospital, treated him for the trauma. He didn't survive. They didn't test him for hep C either. Why would you? So this is the flaw, if you like, in the system. And not all processes sterilize tissue. Interestingly enough, neither the US nor, for example, the Human Tissue Authority in the UK require that allograft be sterilized. And you might think, well, the risk is incredibly low, and you're absolutely right. The risk is incredibly low, but from our perspective, and generally tissue processors over time have developed the approach that we should process tissue to assure safety to the greatest level possible, yet preserve the biomechanics and ultimately the clinical utility of the tissues. And there's a balance there. So if you left it alone and everyone still had their little bone banks and their small tissue banks in their refrigerators and their freezers in their department of orthopedics, we would have pristine tissue that is optimal in terms of freshness, but there's a risk. And you also have the 60% fallout because you lose it to microbial contamination. So there's a balance here. We want to process to make it safer. We don't want to process to make it less clinically effective. Now let's talk about processing. Get some terminology down. Aseptic processing simply means that you minimize the potential introduction of potential adventitious organisms. So you try not to add anything to the existing flora. Existing organisms are not treated. So when you hear that something is aseptically processed, it will have been processed typically with water and maybe some alcohol, and it will be microbially tested at the end of that process to see if residual organisms exist. Sterile processing is another term that's used in tissue banking. All of these terms are arguably designed to confuse. Sterile processing means aseptic recovery of tissue, typically in an operating room, so you think about how sterile is your operating theatre. It's clean. It's not really sterile. So the term sterile processing is probably a little bit of a misnomer. And then the tissue may be treated with gamma irradiation. It may be treated with low temperature chemical sterilization. So what does sterilization mean here? Well, in order to assure that you actually sterilize tissue, you need to be sure with human tissue that you're dealing with viruses as well as microbial flora. One of the keys here is most of the tissues that are recovered are reasonably highly vascularized, and therefore the chances are that bloodborne pathogens are actually embedded within the tissue matrix. So you need to be able to perfuse the tissue or to penetrate the tissue with your sterilants in order to actually make sure that your tissue is rendered sterile. The sterilization processes need to be validated, which essentially means they're reproducible on a large scale. They're supposed to inactivate and remove pathogens to a specific predefined level. The key is preserving the biomechanics and the biochemical integrity where possible when you're doing this to the tissue. The processes are going to need to be scientifically proven and clinically successful, and I go back to my first comments, and that is, as a profession in the tissue banking world, coupled with as a profession in the medical practice world, we really haven't done a good job of partnering to make sure that we've got evidence of clinical success. So we all know that a biological solution, particularly for some of our younger patients, is absolutely the best solution. And I work for a company that has metal and plastic, and we'll supply them all day long for the patients that have progressed beyond what biology can do for them. But we have a responsibility to give a biological solution to a patient, to buy them that extra time before they finish up with a total knee replacement at 50 years old. And the processes need to be validated by tissue type, because different tissue types actually respond differently to the sterilants, partly because of their configuration.
So cancellous bone is relatively easy to clean and sterilize, to be honest. It's a fairly open matrix. An Achilles tendon is phenomenally difficult to sterilize. If you can all visualize that dense collagen bundle at the bone-tendon interface. So how do you get, pathogen out of there, yet preserve the biomechanics of it? What are we trying to achieve? What are we trying to inactivate or remove? And this is basically a table of the organisms that were used as a panel of organisms to validate a sterilization process that was developed. In fact, several sterilization processes that were developed by RTI. Very common panel, typically used in the industry. It's not RTI specific, except for Clostridium, and I'll come to why Clostridium is relevant a little bit later. So the process that we're talking about, and the process that RTI developed first, was a process called BioCleanse. And we began to develop that in the late 1990s. And the goal was to remove blood, fat, lipids. Those are basically the disease vectors, the pathogen-carrying vectors. This is actually a femur that was on the right-hand side, is a femur that went through the BioCleanse process intact. And really the only point of this picture is to show that the femur is completely decellularized. So those pathogen-carrying blood, lipids, and bone marrow have been completely removed. On the left-hand side is actually a femur that was sectioned after being retrieved from a refrigerator in a hospital in Florida, and it had been supplied as a cleaned femur by another tissue bank back in 1998. So clearly it was not cleaned. Now, on the outside, because it had been soaked in peroxide, it looked white. On the inside, this is what we were dealing with. So very, very different picture. So just very briefly, and this is really just to give you a sense, and there are a couple of slides here, to give you a sense of the different processes that are out there. Excuse me. BioCleanse is the process that we developed first, particularly for bone and ligaments. There's a disinfection and irradiation process that's available called Allowash, again, very successful. And I think one of our colleagues, Phil Davis, really said it very well a couple of days ago when we were out at the meeting in Brussels, is when we're talking now about high-level tissue processing, what we're really talking about is choosing between a BMW and a Mercedes. What we're really saying is that these processes are generally effective. And what really needs to happen next is they're effective in terms of sterilization. What needs to happen next is proof of the clinical outcomes based on the use of these processes. And what the processes do bring, they do bring an assurance of safety. And they do bring a greater degree of tissue availability. Again, we see less than 2% of tissues failing to be released through these processes, whether it's RTI's process, or LifeNet's process, or Allosource's process, and there are more. Less than 2% of tissues fail to make it through those processes and be deemed safe. However, how many of them really are then tested for clinical efficacy down the road? Very few of them. And that's in comparison with 60% rejection rate. So as you see some of the tissue banks in Europe, perhaps, that are less sophisticated in terms of their tissue processing, they're still, as well as having the complex regulatory environment in Europe with these 28 sets of rules, we also see about 60% of the tissue that can be gathered being lost because it fails the microbial cultures, because there are not really well-developed sterilization processes available in Europe. So this is the challenge that we have. This is the challenge that you have. You really don't know what you're getting, because tissue processors have become very skilled in mimicking device-type packaging. So we all provide, this wonderful-looking sterile packaging, and it'll tell you, the RTI product, it looks like a sterile product. The MTF product actually is an aseptically processed product. It's packaged in exactly the same way. You really couldn't tell when it shows up in your operating theatre whether or not which one's been sterilized and which one hasn't. So it really is pretty important to understand that what you see is not enough. You may want to ask some questions. And if you do elect to go for an aseptically processed graft, you understand what it is you're dealing with. If you elect to go with a sterilized graft, then you should probably be asking, so what sort of preclinical testing did you do to show that you didn't disrupt the collagen matrix? And what sort of clinical data are you developing to show that the clinical efficacy of these relatively highly processed tissues now is actually beneficial to the patient? So let's talk about the preclinical study. So one of the things that we have done, and I know a couple of other tissue banks in the US have done as well, is carried out preclinical work, basically bench testing, both on this side of the Atlantic and others actually. Ian mentioned Andrew Amos, and we've done quite a lot of work with Andrew. He's a phenomenal brain, especially in biomechanics. So structural analysis, molecular analysis, sterilization, efficacy, all of these are the questions you should feel perfectly at liberty to ask your tissue supplier. What work have you done in this regard relative to the tissue you're providing to me? And you can stack rank where those questions lie, I think, based on the level of processing that may have taken place with the tissue. So if you're going to obtain an aseptic tissue, you probably want a more in-depth conversation about how do I know this is safe. It's probably not been manipulated or processed very highly, so some of those other questions may not be as relevant. When a company comes to you and tells you our tissue is super safe, it's been sterilized, then you probably need to be asking some of those other questions. So it's basically a checklist. Well, show me what work you've done in this regard. Just a couple of examples of studies that we have performed internally. One of the things that we did after our biocleanse process was we took a look at had we disrupted the collagen structure. Pretty critically important in ligamentous tissue, for example, for ACL reconstruction. And as you can see, using scanning electron microscopy, the collagen structure has been retained. Similarly, biomechanical analysis, we did testing for failure load, elongation. Obviously laxity is something that would be a concern over time, as well as stiffness, and again, no statistical difference. Structural integrity, here we're demonstrating that while we've removed the cellular elements, again, the collagen has remained undisrupted. And not cross-linked, by the way, which is another effect that can come about from certain types of chemical processing. And while it can certainly help to render a tissue sterile, cross-linking can increase its stiffness and actually create catastrophic rupture. Molecular analysis, so as well as looking at it from an imaging perspective, we took a look at did we alter the biochemical nature of the collagen? So did we break down the collagen to an extent that then the collagen may not survive over time in a manner that would be acceptable? Again, collagen digestion studies, and the positive controls were high heat treatment, which are known to have collagen degradation capabilities. We then went on to large animal studies, and in our world, the sheep and goats are the regular models. So sheep BTB autograft versus a process, that's biocleanse process, sheep BTB allograft, time points out to 52 weeks. And we did all of, if you like, the standard assessments that you might in a study that was going to assess clinical outcomes in an ACL reconstruction in a human. Histologically is where I really want to focus here. The biocleanse process allograft pre-implantation was cell-free. Biocleanse process allograft 12 weeks post-op is showing cellular infiltration. And I think what is really critically important here, and it may not come up in this talk, but I know it is a point for discussion, is donor age. And what really matters here? And the answer is, the quality of the collagen from the donor is what matters. And the quality of the collagen from the donor is far more associated with lifestyle and comorbidities than it is the age of a donor. So we hear about the 50-year-olds that run marathons. I will guarantee for you that their ligamentous tissue is far better quality from a collagen perspective than a 25-year-old smoker who's grossly overweight. I guarantee you that their collagen is of better quality. And as we think about putting these scaffolds into place, what we're seeing here, and this illustrates this, is we're seeing cellular infiltration. And why is the 50-year-old athlete, why is their collagen so much better than a 20-year-old couch potato who's a smoker? Well, it's because they're exercising it and they're turning over the collagen. We are not putting in spare parts. We're putting in a scaffold that the recipient will remodel over time, providing the scaffold is suitable and can allow for the cellular infiltration to allow that remodeling to take place. So the 50-year-old guy who's got good ligamentous tissue is not running around with the same ligamentous tissue that he had when he was 20. He's turning it over all the time. So we've got to think about biology when we start thinking about that. Now, I know that's a huge point of contention. And, you know, if somebody asked me, would you let somebody put a 70-year-old tendon in you for ACL? The answer is, for me, the answer would be yes. But then I have all of the testing data that you don't have. So it would be a very interesting conversation to have for another day. And then similarly, at 24 weeks post-op, virtually identical cellular repopulation. So what you're seeing here is cells infiltrating, which is the first step towards the proper healing process. Just touching on meniscus, because I know that's a big part of our discussions today. We also performed in vitro biomechanical and biochemical evaluation, compared aseptic meniscus, that is essentially alcohol washed meniscus with biofilm process meniscus. We did compression testing because while for ACL and ligamentous type grafts, we're looking for very specific properties. In meniscus, we want something to retain its shock absorber capacity. And significantly different biomechanical characteristics that we're looking to retain. So compression testing and then tensile strength testing, as well as biochemical tests. Have we altered inherent material here? And again, the collagen structure, the collagen makeup in a meniscus is entirely different from that of ligamentous tissue. So we did GAG content, collagen content, and susceptibility again to enzymatic degradation. So these are the results. Aseptically processed versus bioplants, and essentially no statistical difference. And again with the GAGs. So moving on just to one article, and then I want to touch a little bit more on clinical results and then literature. There was a paper recently in AJSM that talks about novel sterilization process. It was a bioplants process. Other papers have been written on other processes. And equally divided between bioplants irradiated and fresh frozen, measured for cross-sectional area and looped over a smooth rod. So very standard methodology, done out of UCSD and independent of RTI. They sourced the grafts from us. They performed their own study. And their conclusion was that the physiological stiffness and failure loads indicate that the bioplants process doesn't adversely affect the biomechanical properties of the allograft material. Very nice for us, very nice publication. The next question we get from physicians is, well, what does that mean in the clinic? And the answer is, we have very limited data on that, and we have a responsibility to go get more. So let's talk about those clinical outcomes. There are various published studies. I'm going to focus a little bit on infection risk and then really into biomechanical properties and clinical outcomes. So talking about infection risk, I mentioned Clostridium was one of the organisms that we utilized to validate our bioplants process some 15 years ago. And we selected that organism because it is an organism that is relatively commonly seen on cadaveric tissue. And it's a gut organism that, again, proliferates through the peritoneal barrier post-mortem. So not unusual to see Clostridium. So we elected to utilize Clostridium sporogenes as one of our challenge organisms. That was back in 1999-2000, just as we were finishing the bioplants process development. In late 2001, a young man in Minnesota died from a Clostridium infection as the result of being implanted with a fresh osteochondral allograft. Devastating for the tissue banking world and clearly devastating for this young man. What was actually happening at that point in time is the US FDA had asked to see our bioplants validation data. They saw Clostridium. They sent the CDC to us. CDC wrote a paper about the fact that you can actually sterilize tissue because that was pretty much unknown at the time. And personally, while as a company they may think differently, personally I'm very gratified that RTI was the first company that sterilized tissue, but is not the last. Because there is no benefit from my perspective as a scientist in being the only company that has very limited ability to provide a safe allograft. The fact that many other companies have fast followed to develop sterilization processes, I think, is just to everyone's benefit. And again, so this is not a commercial for RTI. This is really about let's find the optimal way to process allograft, retain the biomechanics, and give us best clinical outcomes. Another paper talks about low-dose irradiation not killing HIV. So when you hear about irradiation is bad, generally speaking, high-dose irradiation is detrimental, particularly to collagen, so to ligamentous tissue in particular. The bone tissue is less susceptible to damage by irradiation, but certainly ligamentous tissue can be definitely damaged. Here's the dilemma. If you rely on gamma irradiation as your mechanism for addressing potential viral load, you have a problem because it actually requires about 5 to 8 times the normal low dose of irradiation to achieve a kill for HIV. Why is that relevant? Well, it's relevant for Zika virus because Zika virus is part of that family. Now, what I will say is, of all of the tissues that you should be concerned about with Zika virus, the only one I would be concerned about in any way for the moment would be placental and amniotic tissue, because it's very clear that Zika virus is crossing that barrier, that placental barrier. To my knowledge, most of the amnion-derived graft materials that are available in Europe, many of them from the US, do have some treatment by irradiation. So I think you're all relatively safe. But if anybody is going to ask you that question, those are the types of tissues that are probably most risky and susceptible today as we speak to the virus. So let's talk about irradiation again a little bit. Numerous studies suggest that pre-treatment of allograft with irradiation results in poor clinical outcomes. And I will absolutely acknowledge that most of these studies are anecdotal, retrospective, not terribly well controlled. But there are many of them out there, so when you start to see the volume, it's something that probably needs to be paid attention to. And certainly in 2007, Raff and Indelicato out of the University of Florida reported that they had a significant difference in irradiated versus non-irradiated Achilles grafts. So in full disclosure, those irradiated grafts were provided to Dr. Peter Indelicato by RTI. They were provided before we perfected BioCleanse for Achilles. We perfected BioCleanse for Achilles in 2006. He subsequently went on to use only BioCleanse Achilles, had no failures afterwards. So we provided an irradiated graft when it was the only safe mechanism we had. We developed a different mechanism which we believe gives better clinical outcomes. So I have first-hand experience of watching if you like, the metamorphosis from the use of irradiation to the use of non-irradiated tissues and seeing a difference in clinical outcomes. And so we're not saying that irradiation should never be used. It was our only option until we could perfect BioCleanse. And once we perfected BioCleanse, clinical outcomes were clearly more advantageous. And again, many articles that talk about the diminished effectiveness, clinical outcomes for the use of irradiation. All right, so I also wanted to touch for the last 10 minutes or so on the literature. And again, one of the challenges here with the literature is these registry reviews, these systematic reviews, none of them are really level 1 clinical data. And we have to start putting level 1 clinical data together. Many of us have a sense that the use of allograft is beneficial to many of our patients. But we're, again, sort of navel-gazing here because we all believe that there's probably some benefit in using allograft material, biological scaffolds, for our patients. But we have to prove it to the outside world, we have to prove it to the payers, and we owe it to the patients, quite frankly. So, in that, from that perspective, I just wanted to cover some positive literature on the use of allograft and some not so positive literature on the use of allograft. Because I think in all fairness, we need to collectively understand what's out there so that we can coalesce and decide on what studies we believe need to be performed in order to put a compelling story together to prove the clinical benefit of the use of biological materials, biological scaffolds, because that's what we're talking about here. So autograft versus non-irradiated tissue. It was a positive review in that, you know, it basically said there were really no differences. Effective graft tissue on ACL outcomes, multi-center prospective randomized control with fresh frozen autograft hamstrings and fresh frozen allograft. Again, use of fresh frozen tibant, none treated for ACL reconstruction, similar outcomes to autograft. On the negative, here there was no control for processing type of or method, and the conclusion was you shouldn't use allograft in the young military population. Interestingly enough, there are other studies about to be published that say quite the opposite. Again, much of it anecdotal. Here, conclusion, you know, allograft processing, surgical technique, rehab protocol might contribute to poor results. Not controlled for any of those variables, and not really controlled for fresh frozen and irradiated, not good analysis of the variables. Study that suggested that allografts may not be clinically viable for young active patients. This is the MIM study, for those of you that are familiar with it. No control for source of allograft, and all were irradiated. And in talking to the tissue banks that provided these grafts, some of them used very low dose irradiation, some of them used pretty significantly high dose irradiation. So where do the results, what do they really mean to us? And then this most recent one, the Kaiser study, that actually calls out bioplans, and we were pretty mortified when we saw this, but then we started to dig into it a little bit more. This is a registry from the Kaiser, it's a system in California, and it says that there's a greater risk of revision with bioplans. So we start to dig into the data a little bit, and we do have comments into the authors at this point in time. Bill Garrett out of Duke is working with us to help to perhaps address this. But reality is, you know, these data are flawed because the study groups are completely mismatched. About 40% of the overall population was completely lost to follow-up. So what conclusion can you really draw? And what is really quite interesting to us as a group of tissue bankers in the United States is, well, everyone wants to believe that, you know, these numbers relative to specific processing methodologies are relevant and realistic. Nobody believes that you only actually see a 2.61% of allograft-associated revisions. They all think it's more like 20%. So we clearly have a lot of work to do in both educating the surgeons on how to properly evaluate different methodologies, how to properly evaluate registry groupings. And so as you're talking about registries, how you set up the registry to properly capture data is critically important. Otherwise, you're going to finish up with something that doesn't really make any sense to anyone. And then finally, on age. So this is related to actually young patients. A series of 61 patients. This is actually with a mean age of 20. And what is pretty significant here is these were ACL repairs or replacements. They did go back to pretty high levels of activity. Now, from my perspective, that's a relatively dangerous pursuit. And I do think that we do need to be very, very careful, I think, to Ian's point and a couple of other people. You really do need to be careful about what expectations you set with your patients. Kevin Stone is a really great friend of ours. Kevin Stone has an insane patient population. I don't know how many of you know him. He treats the ex-skiers, the ex-games folks. And he tells them they can go back to those same activities. And some of them do incredibly well. Many of them do not do incredibly well. And they become patients for life. because they, and he will do multiple redos on some of these young people. But they literally, they go hot dog skiing within 12 months of some pretty significant meniscal repair, ACL repair, restabilizing, multi-ligament repair. And it's basically insanity. So I do think we need to be careful when we're talking about younger patients and what we're going to do for the younger patients. Whether they're having an autograft or an allograft, we need to set their expectations. Because if we perform a significant surgery, a multi-ligament reconstruction, a meniscal replacement, and then they think they can go back and do what they always did before, then we really haven't gained very much for them. We've maybe gained a year. And then they've got many, many years of misery to go before them. One last study, I think. This was it's the only one that we know of, the only study that we know of, where there was a prospective randomized approach. It was statistically relevant. The sample size eventually was quite small. It was less than 100 patients. We started off enrolling 120 patients, and then the irradiation arm, basically the surgeons refused to implant any more irradiation grafts. So we finished up with a 2-arm study, and there were about 65 patients with 2-year follow-up. So interesting, promising, but inadequate in terms of the overall body of literature. More of these types of studies need to be performed. In summary, there was a significant difference in outcomes between non-irradiated allograft and autograft in that study. Studies suggesting allografts have poor clinical outcomes, have not controlled for processing, and non-irradiated grafts appear to be clinically viable for young active patients and an attractive alternative to autogenous tissue, but again with the appropriate counselling and rehab protocol. And those are my comments, and thank you very much for your time.